The broadcast is now starting. All attendees are in listen-only mode.
Good morning. This is Melissa Wilson-Vickroy with the Kentucky MGMA. Thank you for joining us this morning. We still have a few people logging in, so I'm just going to go over a few administrative things before we get started. First of all, you should have received a copy of today's handouts. And if you didn't, please just shoot me an email and I'll make sure that you get those. Second of all, the webinar is eligible for one ACMPE credit hour. You do not need any documentation from us, but should you want something from me just to keep for your records, just let me know and I can get that to you as well. The other thing is, if at any time during the webinar you think of a question or have any problems, if you look down on your screen on the right hand side, there is a questions box. You can type your question in that box and I will be monitoring that during the webinar. And at the end of the webinar, Dr. Gregg will take questions and you can type your questions in that box and we will take a few minutes to answer as many of those as we can. The final thing is today's webinar is sponsored by MagMutual Insurance. MagMutual has been a long-time sponsor of KMGMA programs and has always supported our educational efforts. So we want to thank them for organizing our presenter for today. With that being said, I will introduce Dr. Gregg. She's the president of the Patient Safety Institute for MagMutual, and she oversees the risk management and patient safety activities of the company. As the Chief Medical Officer, she's responsible for developing and implementing and communicating patient safety initiatives at the Patient Safety Institute. Her full biography bio was on the materials for the webinar if you need more information. And again, we thank MagMutual for securing Dr. Gregg as our presenter today. With that being said, I'm going to turn everything over to her, and if you have any questions, please feel free to type them in the box, and we will get to them as soon as we can. Thank you.
Thank you so much, Melissa, and I want to thank the Kentucky MGMA for the opportunity to discuss this really important topic. Since the Landmark Institute of Medicine report to err is human, there's been a lot of attention given to patient safety. But as you know, most of these initiatives have centered around inpatient care. And even the number of studies funded by the Agency for Healthcare Research and Quality, AHRQ, on inpatient safety have almost been tenfold that of outpatient studies. And quality and safety initiatives, even by Medicare, have focused on inpatient. But now the tide, I think, is turning, and we're beginning to see in the transitions of care and continuity of care how important it is to get risk and patient safety right when it comes to the outpatient and office setting. This is a list of our objectives for education in this next program that you'll hear. So I just want to hit at the top of this in a big picture, and remember that ASHRM is focusing now on enterprise risk management and the opportunity to really be proactive. This is a nice framework of activities that really helps to identify and manage risk by considering all risks across your organization, and it can be used in any kind of setting. And they really organize the approach into risk domains that help you identify and manage risk more easily. Examples of these domains are from the top, operational, which includes adverse event management. The next is clinical patient safety, which is associated with the delivery of patient care. For example, failure to follow evidence-based practices and medication errors fall into that. Strategic domain is associated with the business focus and direction of the organization. The financial risks obviously affect profitability, cash, access to capital, and malpractice And litigation really does fall under that financial domain. Human capital is our HR and employee recruitment, and really refers to your workforce. There's the legal and regulatory, which are risks of failure to identify and manage and monitor your mandates. Technology and hazard at the end are really risks relating to losses of assets. But just as a reminder, this is a way to look at your organization. Just start with overall assessing where you stand. So from the medical liability viewpoint, we see claims falling into the following categories. Surgical errors, that is the most common allegation in the inpatient setting, and that comprises 34.1%. Diagnostic error is the most common allegation in the outpatient setting, and it comprises 35.9% of these claims. And then overlapping, 8.9% of errors include failures in both the inpatient and the outpatient setting. With diagnostic errors making up such a large percentage of claims, it's important that we analyze the process and really identify opportunities for improvement. This is an excellent reference for those of you that are interested. Singh examines diagnostic errors in this article, and the objective was really to determine the types of diseases that were missed and diagnostic processes involved in cases of confirmed errors in primary care settings. They reviewed the records of diagnostic errors and looked at what they called triggers that were based on patterns of patients' unexpected return visits after an initial index visit. They actually identified 190 unique instances of diagnostic errors detected in primary care visits over just a year. And the data really was collected based on presenting symptoms, types of diagnoses that were missed, breakdowns, and potential for harm. So out of that, they had 68 unique diagnoses. We are not surprised that most misdiagnoses were common conditions in primary care. Pneumonia, heart failure, kidney failure, cancer, and urinary tract infections were the most common that were missed. But what's important here is that process breakdowns, all right, these frequently involve the patient-practitioner clinical encounter, but were also related to their referrals, patient-related factors, follow-up and tracking of diagnostic information, and performance and interpretation of diagnostic tests, all of which we will cover in this discussion. So a total of almost 50% of cases involve more than one of these processes. Patient-practitioner encounter breakdowns were primarily related to history taking, with 53%. Examinations, just a physical exam and missing some of these, or not doing a complete exam, and then ordering tests, and they overlap. So diagnostic errors were really identified as a common problem in outpatient settings. The researcher also noted that the outcomes of paid claims were not trivial. Roughly 70% of these involved death and grave permanent injury such as brain damage or stroke or a major injury, compared to 81% of inpatient outcomes. The average payment for outpatient malpractice claims was $290,000. That's nothing to sneeze at either, although it was considerably less than the inpatient of $363,000. the paid claims record in physician offices, the investigators said, is a call for patient safety advocates to pay attention. The top 5 risks in the outpatient setting include the following. Patients seeing multiple providers. That is a red flag for problems with diagnostic errors. When they see multiple doctors in a single practice, the chance of a misdiagnosis is more than double. The second is coordination of care. Providers are often too busy to talk to each other. The third is multiple transitions from acute care, rehab, office. When patients are discharged from an acute care facility and then they see their PCP, at least 30% will see the PCP without a discharge summary. Physicians, and number 4, are not always available. They may be seeing new patients in a procedure or on the phone with another patient. And last, patients often don't want to bother coming to the office and would rather rely on telephone advice. Be careful. The CRICO Risk Management Foundation in 2007 did a study that identified the key issues related to office-based medical liability claims. Some key findings of the study included more than half, 52%, of CRICO's office-based claims alleged either a delayed or missed diagnosis. The most common diagnoses were cancers. Others were failure to diagnose infection, heart attack, benign tumors, and strokes. The common root causes in office-based failure to diagnose cases were poor clinical judgment, poor clinical systems, and inadequate communication. Conducting an adequate history and physical, ordering of diagnostic tests, and test interpretation were of the focus of concern. Cases often had mismanaged medical treatment or medication errors, but they were the most common allegations. And the majority of them were related to poor communication within the system. So what about when bad things happen to patients? Really, patients, and we all know this, do experience adverse outcomes, and sometimes due to medical negligence, sometimes because of relatively complicated procedures, but they have these experiences every day. Although physicians have legitimate worries about being sued, the fact is that fewer than 10% of those patients and families actually file a medical malpractice suit. So why do so many patients with valid claims decline to sue physicians and medical institutions? Patients generally sue because they suffered an injury, and they may have lost income, can't afford their medical care, but really the tipping point as to whether to bring suit depends on the patient's perception of his or her doctor. Gerald Hickson, some of you may know, he's the Senior Vice President for Quality, Patient Safety, and Risk at Vanderbilt School of Medicine in Nashville. He says, there are some individuals who are ready to file suit at the drop of a hat. Luckily, most patients are reluctant to sue, and they're willing to forgive caregivers if they feel they've been respected. You know, you don't have to be warm and fuzzy, but it's really about respect, being candid, and answering questions. Gerald Hickson says when patients feel a lack of respect, it increases the likelihood of an avoidable adverse outcome. If they don't show respect, they don't have a team effort, and then there's a poor outcome, the family is often going to file a suit. The axiom that patients don't sue physicians they like is overly broad, but has some truth to it. And how they communicate with their patients, especially if there's an adverse outcome, it will help to determine the next step in whether they do sue or not. So today we're going to review and discuss each of these strategies, and we're going to start with communication. Preventable medical errors occur with alarming frequency. Communication errors are frequently cited as one of the leading causes of medical errors. The healthcare delivery system is complex and often requires an exceptional amount of coordination among the providers involved in the care of the patient. Just think of how things were even 10 to 20 years ago. At that time, you can think that there was a single provider. The provider took care of the patient and rarely got a consult or had patients go to other physicians. If the patient was admitted to the hospital, that provider would follow the patient into the hospital setting, see them every day on rounds, write the notes, and then see them in follow-up. And now you can imagine, even in a 24-hour overnight stay, patients can see up to 20 different caregivers in that short time. And you can imagine how many people look in their charts, make changes in the charts, write orders, and have some accountability for them at the time of discharge. The communication efforts are huge, and anything can fall through the cracks. The Joint Commission defines the communication root cause as to include oral, written, and electronic communication among staff, physicians, also administration, and the patient and family. During the time period of 2004 to 2011, communication ranked third overall as the root cause of even sentinel events. And most physicians and caregivers are at risk because virtually all of them conduct a patient interview. And Dr. Matt Lipkin, who's one of the editors of the medical interview, says the patient interview is a fundamental clinical skill for all health providers. And the primary care physician, he estimated, conducts between 12,000 and 160,000 interviews during a 40-year career. Whether they're practicing in hospital, office, clinic, or even a research lab, they are communicating with patients. And it's not limited to the physician-patient relationship. You know, there is written information from secretaries, nurses, labs, there's medical records, there's the telephone, the fax, electronic mail, letters, consultation lab reports, countless opportunities for good communication. But unfortunately, there are plenty of chances for poor communication. So at this point, you need to consider in your practice and in your environment what type of handoff and sign-out protocols you have. And this ensures continuity of care. Specific guidelines for the handoff process include interactive, up-to-date and accurate information, limited interruptions, a process for verification, and an opportunity to review any relevant historic data. The plaintiff attorneys, and we have had recent cases on poor communication, really want to know, do you, doctor, have a process for handoff? Not asking what kind of a handoff you have, but to know that you have a standard process that occurs every day when there is a handoff from one doctor to the other, and in particular when somebody else is taking call of your patients for the weekend and you're signing out. Consider using structured communication such as S-bar. Consider using, there's another one called I pass the baton or I pass. All of these result in a structure so that certain items are not missed in the handoff. Patients generally sue because of anger, money, or guilt. People that are pleased, remember this, may tell 5 to 8 others, while those patients who are unhappy tell up to 18 to 20 people, and even more thanks to social media. So implementing safeguards to limit liability, in addition, should be including telephone advice protocols. Listen to your front desk. Be sure that they are not offering any medical advice. Establish parameters for symptoms so that the front desk understands what is important to get immediate triage and what can wait. So front staff need to be very clear on guidelines for telephone triage and notification of a physician. We recently had a case where the front desk would take messages, and the physicians and the PAs and nurse practitioners never received those messages until days later. That is a setup for disaster in your practice. Here's a case study of failed communication leading to delay in care. This is a young woman with a history of miscarriages, but delivered a full-term healthy baby. At 5 weeks postpartum, she went to her PCP with complaints of chest pain, cough, shortness of breath, dizziness, and she was diagnosed with bronchitis. 1 month later, she returned to her PCP with similar complaints. And now she had congestion, she was wheezing, and she had flu-like symptoms. A chest x-ray showed left ventricular enlargement. A week after this, her PCP showed that she had abnormal signs and symptoms and felt that now she was in heart failure. The PCP told the patient to see the on-call cardiologist in the morning for an echo and called the cardiologist to discuss. The patient called the cardiology office, was told the office does not do echoes on Fridays, and was advised there was no urgency. She could be seen on Tuesday the following week. She called her PCP for help, and now the covering PCP said, don't worry, come back in 2 days if you're not feeling well. And that covering doc did not know her history. 2 days later, the patient presented to the ED in acute heart failure. She was diagnosed with postpartum cardiomyopathy with an ejection fraction of 10% and subsequently had a severe stroke. She was unable to care for her baby. The claim settled for a moderate dollar amount. This is what we would all say is the ball was dropped. She called the cardiology office and was told the office does not do echoes on Fridays and was advised there was no urgency. The front desk did not know about the patient and did not have any history. The patient also called the PCP for assistance and was told by the covering PCP to come back in 2 days if still not feeling well. Something was dropped there. It seems clear that the PCP who was covering did not get a handoff, did not get a sign out, and also did not look at the patient's chart. The telephone really is one of the most important communication tools in the medical office setting. However, without controls, the risk of miscommunication and decreased patient satisfaction exists. Telephone calls must be prioritized and routed appropriately so that patients who contact the practice by phone receive proper medical attention in a timely manner. Written policies should address handling of telephone calls, triaging patients, scheduling appointments, refilling prescriptions, and addressing patient questions and problems. Documentation requirements for telephone encounters include the front desk really have clear guidelines. There are established protocols for handling laboratory results and other diagnostic reports. And that includes, and this is very critical, that physicians see the results of all tests that they order. And all telephone communication, either during or after office hours, should be documented. That is one of the more difficult systems that offices have, is knowing what kind of communications occurred after office hours and having that documented in the chart. They may lead to litigation. If something happens to the patient, if there's a poor outcome or an unanticipated hospitalization. Medical offices really should implement a system and consider this, whether it's on paper, electronic, if the physician can call in and actually dictate a brief note, just to make sure that they have documented all telephone calls and treatment advice was provided. Often, after-hour calls deal with what patients perceive to be an acute problem. And if it is not dealt with appropriately, physicians and the practice will be at risk. Now, it's important to close the loop when it comes to diagnostic tests. And this is different than critical results. But if you're going to order a test, you need to close that loop. And if you're going to schedule a test, you need to make sure that you follow through. So important questions are, is there a patient follow-up tracking system which alerts the practice to the patient who has to return? And what date should this occur? And if you don't have some kind of an alert system in terms of follow-up on tests, you need to put something like that together today. Are canceled, missed, and rescheduled appointments documented in the medical record? This is critical, as there are patients who will not go to their referrals, and that certain diagnoses fall through the cracks. And it's recommended that the patient really stays active in this tracking system until the follow-up is complete. And if there is informed refusal, and the patient says that they do not want to have a certain test, that needs to be documented. And there have to be reasonable attempts, and usually 3 of those, to encourage patient compliance. So that means follow-up. And Mrs. Smith, have you gone to see your cardiologist? No. Mrs. Smith, you keep calling, usually 3 times, to encourage them to be compliant, and you document that. All of those, including with letters, and retain the copies in the chart. A test results management system identifies essential screening and diagnostic tests, and all tests ordered are within this system. Any tests that require follow-up, any tests that are monitoring medication levels, such as an INR with Coumadin, and tests ordered where certain blood or pathology specimens are obtained in the office and sent elsewhere. We have seen, and I know all of you probably have seen, where biopsies that were done in the office are lost, and patients then require a repeat biopsy. Document the time and the date when those specimens were sent and try to track those down to be sure that they arrive in the right place. And a really well-designed test system has the patient actually involved in the process. There are processes to track the pending labs, mechanisms to assure that the test results are reviewed and acknowledged. If it's electronic, physicians need to sign off that they have reviewed the test results. If it's paper, have them initial that they have reviewed, and not their PA, not their NP. It needs to be the physician. Time and time again, we see claims where the physician did not sign off and did not know that the chest x-ray showed an incidental finding of a new mass in the right lung, or that there was a positive biopsy result or an abnormal laboratory study, and these get lost to follow-up. The process needs also to work through the weekend. How many times have we heard of patients calling on Saturdays and asking what their INR or ProTime is and how much Coumadin that they need to take for the next several days? You need to make sure that people are monitoring those, and if the office is not open on the weekend and closed on Fridays, that there's somebody in the office who's accountable to follow up with those patients with the results of their lab tests that were drawn that morning or on Friday. These are the type of critical events that will end up in a lawsuit. The risk of not following up is way too high. And really, if the test was important enough to order, it should be important enough to follow through with. Communication really is the #1 root cause, and payouts are so high. And with diagnostic test tracking, it should be appropriately delegated to trained staff, but the physician really is the final one who should discuss the result with the patient. And physicians should instruct the patients even to be part of this process, to call the office if they've not received their test results by a certain time. This really provides a check and balance should a test result become lost in the system. And this principle really applies even to test results that are negative or unremarkable. Notify all patients of their results. Notify when further follow-up is needed. Document these notifications. Instruct patients to contact the office if they have not received the result. Do not place the responsibility on the patient to do the follow-up. And have this process written down. In the electronic system, an electronic footprint is typically part of the process with a validation process. Patients who don't show up for appointments and fail to follow through with treatment recommendations really can present a significant professional liability for physicians. The more common problem areas are repeated failure to keep appointments, failure to have diagnostic testing or consultation, failure to comply with their medication therapy, and failure to follow medication recommendations. Patients often sue physicians for failure to diagnose, failure to treat, and failure to monitor treatment, even when they have not followed the recommended treatment. Additionally, failure to explain the risks of no treatment. I'll say that again, failure to explain the risks of no treatment may place the physician at risk for professional liability claims. All of these missed, rescheduled, canceled appointments must be documented in the patient's medical record, and often that is by the front staff. This documentation can be used later to show the patient's lack of follow-up. A patient who does not follow through with recommended treatment or diagnostic testing is often more likely that patient who is going to sue later. Can you fire a patient from your practice? I would say yes. However, the first thing you want to do is obtain risk management advice. The following are critical. Avoid any signs of discrimination. Provide a written notice to the patient. Provide suitable alternatives of care. Time the termination very properly. And provide access to the patient for their own medical records. The next part of this discussion is on critical test results. These are the ones that need to be addressed immediately. It's important to have a policy that's different than regular test results. These are ones that have a condition that, if left untreated, could be life-threatening or place the patient at serious risk. This is a test result requiring urgent clinical attention. So, for example, a critical test result may be an elevated potassium level or a pathology report indicating cancer. These are two elements that result in successful critical test results management. Closing the loop. Closing the loop provides traceability and accountability, and escalation helps ensure that a qualified provider receives the message and quickly confirms it. But unless these two pieces of the critical test management are communicated to the entire office, things and results can drop through the cracks. The closed loop communication involves sending a message, receiving the message, acknowledging the receipt of the message, and escalating to the person qualified to take the following and the appropriate step. Staff need to connect the right information to the right person using the right mode of communication at the right time, so that everyone can get and fight against the clock in critical situations. Effective communication really will support excellent delivery of care in this circumstance. I'm mentioning informed consent, but you all probably are experts at this. These are the pieces that need to be included in a true informed consent. I can tell you that informed consent is rarely the root cause of any medical malpractice claim. It is important that it is obtained, it is full discussion, and the process is documented clearly. Consent forms really need to be accurate and complete, and be very clear on who signs the form. I mentioned national patient safety goals. They were established in 2002 to address specific areas of concern in patient safety. And for you all, three areas are really, I think, the most critical. Is safe medication use, patient identification, and infection prevention. There are some notable medication statistics that all of you have seen. More than 4 out of 5 adults take at least one medication weekly, and almost a third of them take 5 or more. According to the Institute of Medicine, medication errors harm at least 1.5 million people in the U.S. every year at a cost exceeding $3.5 billion in additional medical costs. The complex process of prescribing, dispensing, administering, and monitoring medication has been analyzed at every single step. We know so much about medication errors, but we are not preventing them. The Joint Commission's 2014 National Patient Safety Goals recognize the importance and challenges in obtaining and communicating accurate patient medication information. Medication reconciliation is not negotiable. I would say offices do it better than inpatient and transfer of care and transitions of care. But the healthcare team needs to be very clear on who is accountable. In a hospital setting, nurses often get the list, pharmacy reviews the list, but the accountable person is the physician who needs to review and validate and verify and clarify. All of these steps, verification, collection of the information, clarification that they are appropriate, and reconciliation, assuring that changes are made, are all critical to medication reconciliation. A transitional point in care, such as a recent hospitalization, can be really vulnerable for an adverse medication event or change in status. One observational study showed that 1.5 new medications were initiated per patient during hospitalization, and 28% of chronic medications were canceled by the time of hospital discharge. That's an important, really important statistic when you see patients who have been in other areas of care and come back with the same crumpled, worn list that they have had for the last 10 years. That list needs to be updated and reconciled. Another study shows that at 1 week post-discharge, 72% of patients were actually incorrectly taking at least one medication that was started in the inpatient setting, and 32% of their medications weren't even being taken at all. So think of how critical the work is in a practice setting to guarantee that patients are taking the correct medication when you see them. 46% of medication errors occur on admission or discharge from a hospital. Therefore, it is a critical piece of coordination post-discharge for all individuals. Measures are included that focus on medication reconciliation in the Physician Quality Reporting System, PQRS. You all are probably very familiar with it, but it is now combining incentives and non-incentives to promote quality information by eligible practitioners and professionals. In 2015, there is a negative payment if these quality measures are not performed. Medication reconciliation, if you look at this, is the number 46 measure, and it is the percent of patients aged 18 years and older discharged from an inpatient facility and seen within 30 days following discharge in the office by the physician and nurse, pharmacist, or practitioner who had a medication reconciliation of the discharge medications and reconciled with our current list. And PQRS offers the following guidance in the ambulatory setting. First, a medication list must be collected. And it's important to know what they were taking and received prior to their outpatient visit. And the list should include all medications, including over-the-counter herbal supplements with dose, frequency, route, and reason for taking it. At the end of the outpatient visit, the physician needs to clarify, based on what occurred in the visit, should any medication that the patient was taking or receiving be discontinued? Should any prior medications be suspended? And have any new prescriptions been added today? This forces all of us to improve the accuracy of our medication system. And remember, those of you who are caring for pediatrics, children are so vulnerable and have a fatal medication errors, and often is because they were given the improper dose of medicine. Giving the wrong drug, using the wrong route of administration, each accounted for 16% of those fatal errors. These are weight-based dosages. Parents, we want to know the weight of their children in pounds, but you have a duty and obligation to record the weight in kilograms for the safety of all of our children. The 6 rights of vaccine administration include the right vaccine, the right patient, right documentation, right dosage, right time, and the right manner or route. Vaccine administration errors we see can lead to patient harm and wasted vaccine and time. The ISMP has reported 433 errors just last year related to vaccines. 90% of these errors reached the patient, 67% were near misses, and 44% resulted in hazardous conditions. And most of these errors are in the outpatient setting. And as you will probably know, the most frequently associated vaccine with an error was the influenza vaccine. And the staff that were involved were MAs, 38%, RNs at 37%, LPNs, 15%, physicians, 5%, and pharmacists in 2%. Tips really for avoiding vaccine administration errors: look at your expiration. Use vaccines with the shortest expiration date first and rotate vaccines so that the shortest are always at the front. Check your refrigerator and freezer often to dispose of any expired vaccines. I can tell you in the inpatient setting, that was usually the first place that the Joint Commission would go to look, was in the refrigerator looking for expired medications. Avoid giving the wrong vaccine. So be careful of look-alike, sound-alike vaccines next to each other. Label your baskets in your refrigerator and freezer. Check all vaccines at least 3 times before administering. Don't pre-fill your syringes unless it's necessary. If you do pre-fill, label each syringe and/or storage bin with a vaccine name. You could also use manufactured pre-filled syringes. And review, staff, the contraindications, precautions, and post-educational materials. Check your vials. Is it Tdap, DTaP, or TD? And these are unfortunately vaccine acronyms and abbreviations that are easily confused. The elderly, medication errors occur in half of the fatalities in patients over the age of 60. Older people may be at greater risk because they often take so many different medications. Watch for declines in renal or hepatic function, and they're associated with a higher medication error. Additionally, patients who have impaired cognition, multiple comorbidities, if they have a dependent living situation, if they typically are non-adherent to meds, and polypharmacy may be at an increased risk. And advanced age is a patient-related risk factor all on its own. The American Geriatric Society has a Beers criteria to develop that alert us about potentially inappropriate medication use in older adults. And these medications, such as those who take sedatives, anticholinergics, all of these set patients up for delirium or falls. When we reviewed all of our claims in the last 5 years, These are the medications that are the highest risk, and if you have to start somewhere today, start with your cardiovascular drugs, your analgesic and opioids, hypoglycemic agents, and anticoagulants. More than 75% of these adverse events from these medications occurred within 1 to 3 days after dosages were changed or medications were started. Patients need to be warned, especially when their dosages are increased or decreased, and those are the times where I think they are most vulnerable. Medication management, update your allergies every time you visit. Maintain a current medication list. Note your over-the-counters. Utilize your teach-back methods if you have a set and an opportunity, and provide your education to your patients. In an office setting, wrong patient, wrong site, wrong procedure, sometimes that's a possibility, but usually only occurring in more of an acute ASC or an inpatient setting. But what's important is here is the role that you all take in that process. And this is part of the culture of safety, is assessing your culture, ideally having excellent teamwork, having systems and patient involved, you're transparent, and your system is accountable. But when you begin to look at wrong patient and wrong site, you need at least 2 patient identifiers, and this includes when you're providing medications as well as doing any kind of treatment in the office. Patients are booked and scheduled for procedures. Often this process begins in the office setting. So if the doctor comes to you and says, I want you to book for Mrs. Smith to have surgery on her right knee, you need to be very careful that that is documented as right, not left, that is overly communicated as right, not left, and the scheduling is performed accurately, the consent is performed accurately, and the patient is notified of which side of their body and what body part is to be operated on. We have seen in these errors where patients have cataracts in both eyes, and it becomes confusing as to which eye is operated on first. Sometimes these have led to devastating outcomes. Infection control issues. I can't tell you how many times we see patients complaining of getting an infection and post-op or post-procedure, and then commenting on whether the office staff maintained a neat and clean office and whether they wash their hands. The majority of physicians who say that they don't wash their hands have all sorts of bizarre reasons why. Reasons like, well, I thought they looked clean, and I have no reason to wash hands. I don't think that that's important. Be sure you have gel available in all your rooms. Make sure that you have multi-dose vials that are cared for appropriately. In the control of infection, don't have sharps containers that are overfilling by the end of the day, and be careful of your biohazards, and keep your eyes open to any telltale signs that staff actually aren't paying attention to all of these critical details. Medical records, you all know all of the problems that we have with legal accreditation accountability. Dictate and complete your records timely, and keep up with those. Information needs to be accurate. We need to have the charts signed, and remember their electronic footprints. Dr. Smith was scheduled to see a patient. Here's an example. He went in to see the patient and the spouse and began noting that he had a history of cancer and heart surgery. Comment was, they looked at me like I was from Mars. He said information from another patient had been entered into his chart and the information was all wrong. He said, I said to the patient, oh, I'm sorry, this is the wrong information in your chart. We'll fix this immediately. His comment was, after that, I had to work really hard to get their confidence back. EMRs are fertile ground for the plaintiffs. Be careful about data, software upgrades, audit trails, pending orders. All of these are red flags for a plaintiff attorney. Remember, there is such a thing as e-discovery, and we can tell exactly when a chart was open and how long you looked at the chart. So if notes are added after a bad event, or if people say that they actually reviewed an x-ray and never did, the plaintiff attorney can see who created the data, when was the record created, whether the record was modified, when it was modified, who accessed it, and when the record was accessed. So in summary, these are some key parts and points in our discussion. First, create a log and reliable tracking system that alerts the patient and the provider to the patient. Make sure you have good follow-up. Make sure that you are documenting and writing if follow-up is necessary. Have a good process to track all of your tests and reconcile and review in a timely manner. Make sure that you have informed consent. I was discussing this with a allergist last week, and when they embark on when they embark on some pretty sophisticated treatment medication protocols, I suggested that they obtain informed consent, and most of the literature now supports that. And some of these medications, as you know, can have significant side effects. So informed consent is not just based on a procedure, but also on a plan of care. Document clear, concise, timely, and accurate. Have med recon at every patient encounter, and remember to use 2 patient identifiers, especially you who are at risk when it comes to providing medications in the office and vaccinations. You need a reliable test for all of that. So we are now ready to accept questions, and I thank you for the opportunity to speak.
Thank you, Mary. I appreciate your time with us. As of right now, we do not have any questions, so if you have a question, please type it into the question box. If after the webinar you think of a question, Dr. Gregg's email address is on the screen and is among your handouts that you should have received this morning. So we'll give it just a few seconds to see if anyone has a question. Oh. The question was, has this session been recorded for later viewing? Yes, it has. I know some of you, I had several emails of people who wanted to view it or participate but were unable to join today. So yes, it has been recorded, and we will post it on the KMGMA website and send it out to our members as well, so that your staff can view that if you have someone else in your office that wants to do that. Are there any additional questions? Okay, well, if there are no additional questions right now, I want to thank you all for staying on the webinar the full time. It's always nice when people don't drop off, and I want to thank Dr. Gregg for her time and preparing today's presentation and hosting the webinar, and thank Mag Mutual for securing her as a presenter. I hope all of you will join us next month in Covington at the Fall Legislative Payer Conference. If you haven't registered now, I hope that you will do so as soon as you get off of the webinar. And Dr. Gregg, thank you so much.
Thank you so much. I enjoyed